Um,
Hi guys, I am Dr. Maheen. I will be taking this Uworld session today. A little bit about me for those who didn't take the session yesterday is that I am Dr. Maheen Hashmi. I graduated medical school last year from Dow University of Health Sciences. I completed all my USMLE Step 1, Step 2, and Step 3 within a single academic year. I was also involved in a lot of randomized controlled trials at Mayo Clinic and Texas Institute of Cardiology. I was also a part of two drug protocols that got recently FDA approved. One was vimseltinib for symptomatic giant cell tenosynovitis. It's a rare kind of tumor, and I'm really proud to be part of the RCT that was involved in creation of that particular drug. I will be here throughout the marathon, and this is NextGen USMLE. You will be having me, Dr. Ahmed, and Dr. Moaz with you guys. If you need help regarding anything, if you want to sign up for the marathon, you can join. You can ask Dr. Hamza about it, and I will urge you to join this marathon. Again, we will be sharing high yield stuff. We will prepare you not only for step 1 but also for step 2 and step 3. Dr. Ahmed will be here, Dr. Moaz will be here. Both are excellent. Regarding Dr. Moaz, you know that he topped in USMLE step 3 with he has the highest score in the world. So we have amazing mentors. I have also matched into internal medicine residency at University of Alabama, and he has matched at Rochester General in internal medicine. So we both matched this year, and we also hope that you guys can also match the upcoming years. We're here to help you guys with not only your exams but also your road to residency. And so it's really important that you sign up for the marathon. And NextGen USMLE is here for you guys, so don't worry about it. Okay, so we will be starting the session now, and I'm gonna share my screen. If you have any questions, you can ask me in the end. Okay. All right. So this is the first question we have for
Hello.
today.
Hello.
Hello, yes.
Yeah. Good evening, ma'am. Ma'am, I just need to know how can I get access to these questions on Uworld? Actually, I have got the subscription late in the evening. So I don't know what questions are these, and
Um, I can't hear you. Can you speak a little bit louder?
uh, good evening, ma'am.
Yes, yes. Good evening.
Ma'am, the problem is I do not have the access. I do not know what questions are this on the Uworld.
All right.
Please appear completely new to me as I've got the subscription late in the evening only.
Okay, okay. So I understand. Don't worry. We do share, daily question task, and these question IDs that I'm solving on Euro will be shared on the group. All right. So you don't have to worry
Then
about it. So that you
are
can
these
put.
shared before the section or after the section?
So they will be shared as task IDs one day before. So what you will be doing with me will be a revision of those questions, right?
Okay, ma'am.
But even after the session, you will also be having shared question IDs from Uworld. Whatever I'm gonna do, it's gonna get shared in the group, so you can put the question IDs in Uworld and you can go through these questions again.
Okay, ma'am. Thank you.
All right. Okay. Okay, so let's start the session for today. We will start reading from over here. ECG, chest X-ray, exercise, stress test, echocardiogram are obtained to evaluate. Okay. If you guys have attended my previous lectures, you would know that I urge you to read the laboratory test first, all right? Or whatever, values are given first. First, we will try to go through that. So if you kind of go through this, we don't have an understanding of what normal is, what not normal is, okay? But what can you kind of figure out over here? What can you figure out from here?
MAP is low.
Mhm. Very good. What else?
Venous blood oxygen seems low. No, I think that's okay. Venous is okay.
Okay, very good. So the RAP is a little bit low, okay? And if you kind of go through the question, you'll find out that there's this 54-year-old man and he has been evaluated for exertional dyspnea. It started 6 months ago. He has no cough or he's saying there's no known history of heart disease, okay? ECG and all the, things are done. He subsequently undergoes right and left cardiac catheterization and the results are as follows. What additional information is necessary to calculate cardiac output in this patient? How do we calculate cardiac output?
Heart rate times stroke volume.
Okay. So what do you think the answer will be?
It will be D, rate of oxygen consumption,
Why?
because we're going to use the fixed principle, which states that which basically calculates the cardiac output by rate of oxygen consumption divided by the difference between the arteriovenous concentration of oxygen.
Very good. All right. Again, so we know that cardiac output is equals to stroke volume and heart rate. So they are usually not that high yield in terms of USMLE prep, and that is why I don't urge the students to kind of memorize the fixed principle. They have never really asked us this on step one. Okay, it's just the Uworld thing that they try to ask questions regarding fixed principle. But on the actual exam, they have never really asked about fixed principle. It's not that high yield. But try to understand the concept behind it. So cardiac output is equal to stroke volume and heart rate. Know that the cardiac output and stroke volume are directly proportional to each other. All right. What is inversely proportional to cardiac output? Can anyone tell me what's inversely proportional?
Heart rate.
Very good. So directly proportional is stroke volume and inversely proportional is the heart rate. Okay. And then you know that there's this thing called fixed principle, and this is that cardiac output is equals to rate of oxygen consumption divided by AV oxygen content difference. Again, nothing, over here that's kind of, explanatory. It's just, root memorization. It's just an equation that you have to memorize for exam purposes' sake. But if you kind of go down for the educational objective, they also say the same thing. It's just an equation that you have to memorize. Nothing that should be explained over here. Okay, very good. Next question. All right. Okay, the catheter is advanced further and then shows periodic pressure changes with a maximum of 25 mm Hg and a minimum of 10 mm Hg. Assuming the results of the procedure are normal, the first set of readings are most likely obtained from which of the following locations? Okay, so the procedure. The catheter records periodic pressure changes with a maximum of 25 and minimum of 2 mm. The catheter is advanced further and then, it turns into maximum of 25 and a minimum of 10. So what is causing these, pressure changes? Anyone? Where?
The pressure increases when the respective part of the heart contracts. So the maximum is the part when, suppose if the right ventricle is contracting, that would be about 25, I think. So I think the answer is E.
Okay, good. Anybody else? Guys, there are 45 people over here. Only one or two are answering. Only they have to take step one. The rest of you have passed your step one already? No, right? So participate. Even if it's wrong, just say the wrong answer. We're not here to judge you. We're here to make you learn.
I guess it's C.
C, okay. Why do you think it's C?
I think it's right atrium.
Okay.
Then from the right atrium, it goes to the left atrium.
Mm-hmm.
At the time of atrial systole, the pressure rises to 25, and at the time of diastole, it decreases to 2.
Okay. So what is the major consensus for this answer?
I think I also go for C, pulmonary artery.
So most of you are saying C.
E.
E.
I think it's E2.
Yeah.
I think it's
Right
E2.
ventricle. Yeah.
Right
C.
ventricle?
Yes.
Okay. Let's see if you're right. Yes. Now, these pulmonary artery catheter waveforms are not that high yield. I don't know why Dr. Hamza put these questions in, but I will talk to him. These questions are not that high yield, but again, you should know that right-sided pressures in the heart, of course, lower than the left-sided pressures because there is lower resistance in the pulmonary vasculature. And we know that the right ventricle diastolic pressure is similar to the right atrial CVP. Okay, what do you mean by pulmonary capillary wedge pressure? What do you mean by PCWP? What does PCWP represent?
Left atrial pressure.
Left atrial. What about CVP? What does CVP represent?
Right atrial pressure.
Right atrial pressure. Very good. Again, CVP is most likely like, like JVP. All right. Just for a second, I know they're two completely different things, but, just for the sake of understanding, try to, memorize that CVP is kind of like JVP. And whenever you have right-sided blocks of the heart, or, there's right-sided dysfunction or something that's, affecting the right side of the heart, there is an increase in the JVP. Why? Because the pressure of the blood starts to backflow, right? And that is why you will see an increase in JVP in most of the right-sided heart failures as well. And also the CVP will also be increased in, right-sided heart failures. Similarly, PCWP will be increasing if, there's any sort of cardiogenic shock, right? I don't know if you have gone through types of shocks, but PCWP is the sole cause of increasing, and that only happens on cardiogenic shock or when there's when the heart has stopped pumping. Why? Because the pressure starts to backflow. Okay. And yeah. All right, so normally the PCWP is 6 to 12. That is what I want you to remember from over here. If it exceeds to, for example, they say it's 20 or it's 30, then that means, there's something that's causing a left-sided blockage of the heart. And that is why the pressure is kind of going back and it's increasing, okay? So be familiar with that. All right, next question. Okay, what does this indicate? What does this arrow indicate?
Calcium.
Like a contraction, because of contraction or something,
Polarization.
the curve is increasing.
Yeah, polarization.
Calcium.
Polarization.
And contraction can be stimulated by the calcium release after the calcium pumps have been stimulated.
This has to be sodium, I guess.
Okay. So what do you think the answer is?
Calcium.
think
Yes,
calcium.
right. Because this is pacemaker action potential.
Phase 0 of pacemaker action potential.
Calcium.
Okay, so I see.
Potassium.
Okay. I hear potassium, I hear calcium, I hear sodium. Everybody has given that answer is everything. So, what is the major consensus for this answer, for this question?
Calcium.
It should be
Calcium,
calcium.
please take calcium.
Is it A, B, C, D, E, or F?
C.
B.
C.
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 All right. Okay. So you need to be familiar with cardiac action potentials. They're very, very important. We know that there are 4 phases that are occurring. So this is sodium, this is potassium, this is calcium, this is again potassium. Can anybody tell me the 4 phases? What are those 4 phases?
Phase 0, phase 1, phase 2, phase
Yeah.
3, and phase 4. In phase
Yeah.
1, there is rapid polarization as
Very
Na positive influx.
Very
Then
good.
in the phase 1, there is a K positive influx, a little K positive influx to the uh, uh, there is also the change is the it is positive inside the cell only, and then in the next one there is plateau phase where there is movement of K positive and Ca positive, and then there is the Ca, and in the next phase the Ca2 positive gets blocked. So there is a rapid movement of K positive outside, which is the fourth phase where we can see the line going down again to the repolarization, and then there is the fourth one, which is the stability, normal, the original change achieved.
Very good, very good. Amazing. Does anybody else want to explain? Guys, this is your chance of learning. The more you're going to explain, the more. Nobody? Okay, it's for your betterment. All right, okay. So again, there are 4 phases of, the heart cycle, and we talked about that. What you need to remember is that in what phase, what's happening in 0, there's sodium, and 1, there's potassium that's kind of going out, and 2nd, there's calcium influx, and then there's this repolarization phase where the potassium is again going out, and then there's this phase. All right, so be familiar with that. And if this waveform can, kind of come into this pacemaker action potential, it can be represented like this as well. So you also need to be familiar with how it's going to look like in a different waveform. These 2 waveforms are very, very high yield for you in terms of, cardiology, physiology. Okay. All right. What is a plateau phase caused by? Can anybody tell me? Plateau phase?
K positive and Ca2 positive.
Very good. So if they would have asked about the plateau, you could, put the answer over here. All right. Okay. Very good. Next question. This ECG does not allow any abnormal changes. Heart rate changes from 70 per minute at rest to 132 per minute at peak. MBP from 95 to 112. Which of the following parameters was most likely decreased during peak stress compared to the resting state in the patient? All right. So what's happened is that there's this man who comes up because of retrosternal chest pain. He has no history of hypertension. BP was normal at every visit. There's no history of cardiovascular disease. The patient undergoes exercise, treadmill, stress testing. He walks for 7 minutes and stops due to fatigue, but does not experience chest pain. Okay, what's happening? What's happening?
Stable angina.
So he's walking for 7 minutes on the treadmill and stops due to fatigue. All right, the heart rate ranges from 70 minutes at rest to 132 at peak, and the MBP ranges from 95 to 112. Which of the following parameters was most likely decreased during peak stress? All right, during stress, what happens?
But like during the stress, the
Cardiac output
myocardial
goes up.
increase.
Vasodilation.
I believe E. Resistance
A total
will be
systemic
decreased.
vascular
Yeah, it goes
resistance.
up.
With
Option
peak
E.
left ventricular and diastolic pressure.
It's E.
E.
All right, again, exercise physiology, very high yield. So what happens when there's increase in muscle activity? There's stimulation of muscle, chemo, and mechanoreceptors. There's also some local metabolite function. What you need to remember in terms of, USMLE step 1 are these 3 things, all right? These 3 things are very high yield. So if there's, stimulation of the receptors, as a result, what happens? Venous constriction, and there's increase in preload. Now, what do you mean by preload? What is preload?
The
The
amount
amount
of blood
of
entering the
blood
right
in
atrium.
the right atrium.
Okay, very good. Increased cardiac contractility and heart rate, and there's resting muscle and splanchnic vasoconstriction. As a result, the cardiac output increases, and the more the cardiac output is increasing, there's increased blood supply to the active muscles. What do you mean by local metabolite production? What do you mean by this? What metabolite is produced when there's increased muscle activity?
Nitric oxide and adenosine.
Nitric oxide is being produced due to metabolism of arginine.
Very good. What else?
Adenosine.
Lactic acid will also be produced because of anaerobic respiration. If there's increase in muscle activity, the muscles will fatigue easily. Why? Because of lactic acid production. All of those metabolites will eventually cause an arteriolar dilation within the active muscle so that the blood can be supplied more to those muscles. And that is why we're having arterial dilation. And if you kind of go down and see this, that's the same they're talking about. Again, if you have a rise in the MAP, there will be a decrease in the total systemic vascular resistance. They kind of go opposite. So that's really important for you to remember. Again, we know that if the cardiac output increases, then what decreases?
Heart rate.
Heart rate. Very good. Again, although symptomatic discharge during exercise causes increased cardiac output and spasmodic vasoconstriction, there's also modest increase in mean blood pressure as a vasodilation within active skeletal muscles, and that kind of decreases the SVR. All right. Okay. Next question. I think I missed one over here. Okay. What is this?
Okay, I wrote it.
Systole.
That's an ECG representation.
Very good. All right. So there's this pharmaceutical company, and they're conducting research on an experimental drug that affects blood flow in diseased tissue. A healthy 30-year-old man is enrolled in the trial, and patterns of normal blood flow through various tissues are studied. One of the patterns are shown below. The blood flow curve was most likely obtained from tissue or which of the following? Where do you see this type of curve?
Left ventricle.
Ventricle.
Left ventricular myocardium.
Why?
Because
during
due to
systole,
contraction of the
the-
coronary arteries, the blood flow to the heart at that time decreases.
Very good. What else?
Left ventricle supply during diastole.
Very good. Again, the blood flow curve will show a cyclical variation in flow during the cardiac cycle, and you can see the maximum flow during the diastole, and minimal flow usually occurs when the systole. So the maximum is occurring at diastole, and the minimum is occurring at the systole. All right, this pattern is it's very unique for the left ventricular myocardium, and you need to remember that for USMLE purposes' sake. What I want you to remember is this educational objective over here. So during the systole, you will see that the coronary vessels that are supplying the left ventricle are compressed by the surrounding muscles. And because of that, the majority of the left ventricular blood flow occurs during the diastole. The systolic reduction in coronary blood vessel is greatest in the subendocardial region. Why? And that is why when we, I don't know if you've read like cardiac pathology as well, you know that endocardium is the most sensitive to ischemia. Right? Why? Because blood flow is the greatest. And that is why in any sort of angina or heart attack, the endocardium is the first to pass out. All right. Again, so that is why it's more prone to ischemia and infarction. And that is why you also have left ventricular infarction is more common than right ventricular infarction. And it's the first to get knocked out in any sort of ischemia or angina. All right. What is left ventricle supplied by? What artery?
Left circumflex artery.
Sorry, what?
Left ascending.
Left ascending, left anterior descending.
Left coronary.
Yeah, left
Very good.
anterior descending.
So the left coronary artery, it supplies the LAD, and the LAD supplies the left ventricle. All right, and then it also branches into the circumflex artery. Okay. All right. So after initial evaluation, he is treated with verapamil. What is verapamil?
Calcium channel.
Calcium
Channel
blocker.
Calcium channel
Very
blocker.
good. Is it dihydropyridine or is it non-dihydropyridine?
Non-dihydropyridine.
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 What are the two high-yield adverse effects for verapamil?
Edema.
Constipation and gingival hyperplasia.
Very good. Constipation and gingival hyperplasia. What you said, edema, it is for dihydropyridine. All right. So, okay. So the tracing below shows the electrical activity of a specific type of cardiac cell in the patient. So where do you see this type of electrical activity? Where, guys?
In the heart.
In the heart, of course.
Nodal areas.
In the SA node, AV node.
Okay.
The nodal
Which of the
system.
following administration most likely have on these cells? So we know that verapamil is a calcium channel blocker. Okay. And so if you kind of
Increased
block the calcium
excitation.
channels, what is it going to do?
Decreased excitation.
Decreased contractility.
Okay. Anybody
Decreased
else?
excitation and contraction coupling.
Okay. Do you all agree with this?
Yeah, decreased excitation and contractions.
It's a
Slow
decreased excitation.
spontaneous depolarization.
I'll
Since
go
it
for E,
blocks
slow
AV node.
spontaneous. Or B.
It's A.
Yeah, I think E is correct.
You say E is correct.
Why was it E? We know that calcium channels, they it's a kind of, I don't know if you read first aid, go through pharmacology or cardiology, and in class 4 anti-arrhythmics, you will see CCBs, non-dihydropyridine CCBs are verapamil and diltiazem, and in that they have made this, ECG, and you will see that, it slows the spontaneous depolarization, and it is prolonging the repolarization. And if you kind of see it over here, you will see this, right? Again, we know that phase 4 is spontaneous depolarization. So what it does, it affects the phase 4 of the cardiac cycle. And what it does is that it kind of slows the spontaneous depolarization so that the heart rate is collectively reduced. See, it's a class 4 antiarrhythmic, example verapamil and diltiazem, and we use it to terminate most of ADNRTs, sometimes recurrent nodal tachyarrhythmias as well, sometimes PSVT, but mostly it's ADNRTs. What they do is that they work by blocking the calcium channels, and they slow the phase 4 depolarization. So, this line, it is mentioned in first aid. If you go through that, you will find this exact line. And that is why I mentioned yesterday, if you're coming to my class, go through first aid and Tacoma, because most of the times you'll get an answer from there. All right, okay. Next. Which of the following is most likely responsible for the patient's hemodynamic change? Again, this is a very first aid oriented picture. Where do you see this? What's happening over here?
Increased preload.
Volume is increasing.
Increased preload.
It's E.
E.
E is the answer.
Normal saline infusion.
Yes.
Yes, I agree with her.
Okay.
How's the
Why? Can anybody tell me why?
Because increase in stroke volume.
Very good. What if it was a decrease in stroke volume? Then what?
Preload is increased.
Blood loss.
That will be B.
Blood volume loss.
Very good, very good. Blood volume loss. All right.
Yes.
Okay. What if there was a decrease in systolic volume? Then what?
Infarction.
Okay.
Myocardial.
Where else do you see a decrease in end systolic volume?
Digoxin.
In C.
in any sort of
AV
stenosis or regurgitation, in mitral stenosis or mitral regurgitation, you will most likely see a decrease in the end systolic volume as well. Where do you see an increase in end systolic volume?
Aortic stenosis.
Aortic stenosis, very good. Where do you see increase in end diastolic volume? Aortic regurgitation.
Mitral regurgitation.
Aortic regurgitation. Okay, yeah, so this
Left
is very
ventricular
important.
hypertrophy.
Yes. Okay, so these graphs are very important that are given on first day. They ask, a lot of questions on step 1 because of this. Go through that thoroughly. Very, very important. All right, next question. During the study, the blood oxygen content of the aorta and several other vessels is measured at rest. The greatest difference in these measurements will most likely be between the aorta and which of the following blood vessels. All right, so they're basically conducting an experiment on human circulatory physiology, and they wanted to assess the oxygen consumption rate of various organs. Okay. Where do you see a greatest difference in these measurements will most likely be between the aorta and which of the following blood vessels?
Coronary sinus.
Coronary sinus has the
B.
least amount of oxygen.
Coronary
Least
sinus.
oxygenated.
Why is it
Coronary
the
sinus.
coronary sinus?
Because it receives blood in diastole, which is already
Deoxygenated.
Again, so what's basically happening is that the greatest pressure difference will be, of course, between the aorta and the coronary sinus. And the reason is that myocardial oxygen extraction, they exceeds that of any other tissue or organ. Therefore, the cardiac venous blood in the coronary sinus is the most deoxygenated blood in the body. And that is why you will see huge pressure differences between them. And due to the high degree of oxygen extraction, it can be only met by an increase in the coronary blood flow. So coronary sinus over here was the right answer. Each and every one. Renal vein does not make sense. Pulmonary artery does not make sense. Portal vein does not make sense at all. Vein, not necessary over here. So again, we're left with one option, and that's coronary sinus. Again, if you didn't even know the answer, you know that these are not linked to the heart directly. So it can be this. All right. Next question. Which of the following changes is most likely responsible for the preserved left ventricular ejection fraction in this patient? So there is this man, and he has participated in longitudinal study, and he has undergone annual testing with echocardiography, and his left ventricular ejection fraction has remained stable. All right, which of the following changes is most likely responsible for the preserved left ventricular ejection fraction? Where do you see a preserved ejection fraction? Is it systolic dysfunction or diastolic?
Diastolic.
Systolic.
Ejection is
Systolic. It's systolic.
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 I'll go for A, cardiomyocyte hypertrophy.
Okay. Why is it that?
Because the left ventricle has to hypertrophize to pump up the blood to meet systemic demands.
Okay. Anybody else?
The hypertrophy is a natural process that occurs with aging in human beings, so that the ejection fraction can be preserved in old age.
I think it's the concentric hypertrophy, so that's why it would be the A. Because with time the heart muscles are getting thicker to pump more blood, so it's a concentric hypertrophy.
Again, yes. So the patient is already of 80 years of age. So in aging, what happens is that hypertrophy a little bit, it starts to happen because of aging. Again, there is this physiological age-related cardiovascular changes that are occurring. Aortic stiffening occurs. There's mild concentric left ventricular hypertrophy. There's conduction cell degeneration. There's reduced baroreceptor sensitivity. That is why there's increase in orthostasis as well. So again, to compensate for the cardiomyocyte loss and increase afterload. What do you mean by afterload?
Blood remain in heart after contractility.
Yeah.
Very good.
The blood that remains, yes. In
So
the left ventricle.
cardiomyocyte hypertrophy CVD, that is mild concentric left ventricular hypertrophy occurs, and that is why there is maintenance of the left ventricular contractility and ejection fraction. Again, a very, very easy kind of answer, nothing to kind of explain over it. This chart, kind of go through it. They won't ask you, the nitpicks details of it, but they would want you to know that if there's an 80-year-old man, probably he's undergoing cardiomyocyte hypertrophy, and that is the reason of, preserved left ventricular ejection fraction in that sort of patient. All right. Okay, next question. Physical examination reveals mild tenderness to palpation over the left chest, and ECG and cardiac biomarkers are normal. She's scheduled for an exercise stress test. During the test, which of the following parameters is likely to be the most similar between the systemic and pulmonary circulation? All right, what's happened? So she came to the emergency department because of nausea and vomiting and left-sided chest pain. She states that the pain began 30 minutes ago while she was playing with her children. She has a history of dyslipidemia and hypertension. The patient's mother died from myocardial infarction, and there's tenderness to palpation over the left side. ECG and cardiac biomarkers are normal. Okay. What happened? Can anybody tell me?
Unstable angina.
Maybe it's angina. I don't know.
Angina, very good. This is angina. How do you differentiate stable and unstable angina?
One resolves, stable angina resolves with rest, and stable angina does not.
Okay, makes sense. All right, how do you differentiate that with Prinzmann's angina?
Unstable would
Resolved
be
in 15 minutes.
resolved by nitroglycerin.
Okay. How do you treat Prinzmann's angina? What do you give in Prinzmann? CCBs, calcium channel blockers.
Vasodilators, it's because of vasospasm.
Yeah, and sometimes
Yes.
CCBs as well. All right, okay, so she's scheduled, and during the test, which of the following parameters is likely to be the most similar between the systemic and pulmonary circulation? What is the answer?
Go with C.
Why?
Because the cardiovascular
Okay.
system is a continuous flow of it's like a circuit. So the blood flow should be almost like close to equal in the systemic and pulmonary circulation in order for the circuit to be continuous.
Very good. Excellent explanation. All right. Again, in order to maintain the blood flow through the body, the blood flow in the pulmonary circulation, it must closely match the body in the systemic, the blood flow in the systemic circulation. They must be equal, okay, because the amount of blood that's going into your tissues should also be coming out at the same time, right? Again, this is true for the conditions of both exercise and rest, and that is why it's a continuous circuit. If the flow of the blood through the pulmonary circulation is less than the blood through the systemic circulation, and that is why, because of that discrepancy, we get angina, right? There's this overload. The heart goes into overload. The heart cannot compensate for the extra demand of the body, and that is why the patient suffers from angina. All right. Okay. So again, we talked about this. The balance is necessary, and that is why blood flow per minute is an excellent parameter that kind of helps us to differentiate if it's a systemic cause or a pulmonary circulatory cause, or it's because of any sort of other cause. Okay. All right. Next question. What's happening? So there's this man who comes to the ED because of palpitations. He says that the heartbeat is fast and irregular. So irregular, okay. He's had no chest pain. The patient drinks beers, but so he consumed a large amount of alcohol. Okay, alcohol irregular, very high yield. Alcohol irregular. Okay, he's otherwise healthy and takes no medications. Irregular rhythm, again irregular. Okay, rate is really high. What are they talking about? Come on.
AFib.
Fibrillation.
Atrial
Atrial
fibrillation.
fibrillation.
Very good. Atrial fibrillation. And that is why I highlighted the beer and I highlighted the irregular, because those are the two high yield things for atrial fibrillation. We also call it the holiday heartbeat. right? Because people drink a lot of alcohol on holiday. Atrial fibrillation usually self-terminates. You don't have to do anything about it. But if the heart rate is really excessive, what do you give in atrial fibrillation?
Beta blockers.
Beta blockers.
Beta blockers.
Beta blockers. Very good. What is the heartbeat in AFib?
That's
D.
D.
No discernible P waves.
D.
So it's irregular.
No T wave.
Irregular. All right. Irregularly
Yeah.
irregular. All right.
Yes.
So that irregular, you will see
Irregular.
this E. It cannot be A. This is representing what?
PVC.
Slaughter.
Bradycardia. Heart block.
That's heart block.
Yeah, E is block.
It can represent heart block.
Mobitz type 2.
Yeah. What is B represented?
Ventricular.
Ventricular tachycardia. Ventricular tachycardia.
This is representing V-tach?
Yes.
Bundle
Yes. Well, no. This is ventricular tachycardia, mountain type waves, right?
Yes. It's
So what do
tachycardia.
you see in C?
AV block 1. First
A
AV block.
A flutter.
A flutter. Arterial flutter.
Atrial flutter.
Sawtooth pattern.
Sawtooth pattern, atrial flutter. What do you see in E?
Sinus tach.
Irregular.
Tachycardia.
I don't know that one.
Supraventricular tachycardia.
I'm not sure what it is.
Supraventricular tachycardia.
But D is the answer.
Okay.
Yeah,
Again, atrial fibrillation. So we know that what's happening is at foci. Where is the rhythm of the atrial fibrillation originating from?
Pulmonary vein.
Pulmonary veins.
Pulmonary vein.
Pulmonary
Very
vein.
good.
Pulmonary vein.
Where is the foci of right atrium? What type of rhythm originates from right atrium?
Atrial flutter.
Atrial flutter.
Atrial flutter.
Atrial flutter. Very good. See over here, I mentioned
Coronary sinus.
I mentioned holiday heart syndrome because alcohol is a very important trigger for atrial fibrillation. You will have irregular waves over here. Again, it's usually asymptomatic. So they didn't give any sort of treatment because I told you it usually self-terminates. Atrial fibrillation, you don't have to worry about it that much because it's going to self-terminate on its own. But if it's really high, then you can give beta blockers. But most of the times, they don't want you to give any sort of thing over here. Again, we talked about that C over here was atrial flutter. You can see the sawtooth waves over here. So E was AVNRT, and I was waiting for someone to kind of say that it was AVNRT. Again, in AVNRT, where do you see AVNRT? In response to what?
Right atrium.
Very good. All right. Okay. So we know that B was ventricular tachycardia. You're going to see, mountain type waves. What do you see in ventricular fibrillation in VFib? What do you see in that? What type of waves?
No identifiable waves, organized rhythm.
Okay. Ventricular fibrillation is erratic, very erratic. Okay, and the waves will be much shorter. They will be like, they will be like this. Okay, they will be much shorter. They won't be wide spaced. If you see wide spaced waves, they're talking about ventricular tachycardia. If you see very close knitted waves and they're kind of erratic, then that means you're talking about VFib. Ventricular fibrillation is the most common cause of death. All right, so VFib, it is very deadly. You need to defibrillate the patient immediately. It's very, very deadly. All right, okay. So be familiar with this. Another thing that I want you to be familiar with is multifocal atrial tachycardia. Okay, MAT. Does anybody have any idea about multifocal atrial tachycardia? So usually it is
different
TY.
There will be ectopic beats.
Very
single
good.
focus ectopic pacemaker.
Very good. So I want you to read about a little bit of about multifocal atrial tachycardia, and the other thing I want you to read about is Wolff-Parkinson-White syndrome, and what are the delta waves? How do they look like on the ECG? I want you to be familiar with that as well. All right, try to go through that. Okay. Cardiac rhythm strip obtained in the emergency shows us this. All right, what does it show? What is this? Come on, guys, very easy.
AV block.
Atrial fibrillation.
How is it an AV block? I am shocked. How is it an AV block?
Atrial flutter?
Atrial fibrillation.
No,
That's AFib.
So what are the waves going on?
Sawtooth pattern. This is AFib.
Atrial fibrillation.
Sawtooth pattern will be for atrial flutter. So this is
Yes.
AFib.
AFib.
Atrial fibrillation.
Yes.
Irregular rhythm. You see that this is okay, this is okay, this is okay. See, so this was 2.5, and then again, see, this is 3. Again, this is 3, and then you see that this is increased. So this kind of difference between the waves, it is irregular. That's most likely you're talking about AFib. Where does it originate from? We already talked about.
Option D, pulmonary veins.
The pulmonary veins. Yeah.
What does originate from the tricuspid valve annulus?
Atrioventricular nodal tachycardia. Supraventricular tachycardia.
Come on. Atrial flutter. Atrial flutter originates from here.
No, atrial flutter originates from coronary sinus.
No, atrial flutter originates from this. You can see. So this is the isthmus, and that's running through that. And there's this tricuspid annulus. Again, it's a re-entry circuit in the atrial flutter. ECG during atrial flutter typically shows that. Again, that isthmus, and there's this tricuspid valve annulus that they're re-entering together, and that is what is causing atrial flutter. All right, okay, next question. ECG reveals a heart rate of 120 with an irregular rhythm. All right, narrow QRS, no organized P waves. That means we're talking about AFib. Which of the following physiological factors most likely determines the ventricular contraction rate in this patient? All right. What do you think will determine that?
That would be
AV node refractory period.
I think it's the AV node.
yes, B.
Yes, AV node.
That would be B. AV node refractory period.
Phase
B.
4 of the pacemaker potential will be prolonged.
Sinus node is far. Yes, it's AV.
Again, we know that the ECG findings were very, responsive to atrial fibrillation. Again, they're absent P waves, irregular RR, interval, narrow QRS complexes, very high yield for atrial fibrillation. We know where the foci usually originate from, and that is the pulmonary vein. And we know that the ventricular response in AFib is dependent upon the transmission rate of the abnormal atrial pulses through the AV node. And that is why each time the AV node is excited, it enters a refractory period during which additional atrial impulses cannot be transmitted to the ventricles. And as a result, the majority of the atrial impulses, they never reach the ventricles. All right. This is very high.
Could you please explain this again?
Yeah. Did anybody understand? Does anybody else want to explain?
Yes.
What?
I don't understand too.
All right. Does anybody else understand? So what is happening in atrial fibrillation? In atrial fibrillation, why is this irregular rhythm going on? Can anybody tell me that? Okay.
Some of the impulses reaches the ventricles, some not. That's why.
Yeah. And why do you see an absent P wave? Why is there any absent P wave? What does P wave denote?
Arterial depolarization.
Depolarization.
Arterial depolarization.
Atrial depolarization. Okay, and when that is absent, then what does that mean?
The problem with the atrial. It means
The atrials are not
it means
contracting.
there's problem with the atrial,
Atrial.
and maybe there's a diversion. The rhythm is coming from elsewhere other than the atrial.
The electrical signal is not. It doesn't synchronize.
There
Okay,
is no
yeah.
signal going into the node, isn't there?
Yeah. So what's basically happening is that the AV node, the atrioventricular node refractory period, which means the after the impulse has been propagated, it enters into a refractory period, and that refractory period, it regulates the number of atrial impulses that are kind of reaching the ventricles. For example, if the atrial AV node, it enters a refractory period for like 4 seconds. That means for 4 seconds, no impulses can be transmitted to the ventricles, right? It means that, right? But if it enters it only for a second, right? And that means the number of impulses reaching to the ventricles will be greater in number, right? Because it just entered a refractory period for a small period of time as compared to a larger period of time. And that is why we're having fibrillation, okay? So the physiological factor that determines the contractility, the ventricular contraction, is dependent upon the AV node refractory period. For example, if the AV node is, refractory for like 10 seconds or 20 seconds, lesser number of impulses are going to go to the ventricle, and the heart rate will definitely get reduced, right? Because the impulses are going less, because the AV node is taking a chill pill. But if the AV node is, constantly getting excited, and the refractory period, the rest period is very shortened, then the number of impulses will increase, and as a result, the number of heart rate will also be increased. Okay, and that is why it depends upon the rest period of the AV node. Is it clear to everyone?
Yes.
Crystal.
Okay.
Sorry,
Alright.
can you take it one last time? Sorry. Can you take it one last time?
Yeah, sure. Okay, so what's happening is that we know that the AV node is like the boss over here. How do we know it's the boss? Because, impulses have to pass through the AV node to reach to the ventricle, right? So if the AV node is under, a lot of rest, he's taking a lot of time period for the rest, so lesser number of impulses will be able to pass from the AV node, because, he's in transition period for a very long time, and thus the heart rate will reduce. But if the AV node's rest period is very less and it's getting excited more and more, that means greater number of impulses are passing to the ventricles. And as a result, the heart rate will increase. Hence, atrial fibrillation occurs. Why? Because we know that atrial fibrillation is an increase in heart rate, and because of an increase, irregular rhythm, right? It is one of the causes of tachyarrhythmia, right? And that is why it's occurring, because the AV node's refractory period is less. If the AV node's refractory period would have been more, then this fibrillation wouldn't have been occurring. Okay, so the boss over here is AV node, because it all depends upon its rest period. If it's taking 2 seconds for it, then of course, then that means, greater number of impulses are going to go through. But if it's 10 seconds, then lesser number of impulses are going to go through. Okay,
Makes sense.
understood?
Yes.
Okay.
Yes. Thank you.
All right, okay. So compared to at rest, which of the following changes is most likely to be observed during moderate to heavy exercise? Solid line at rest, dashed line during exercise. Okay, so the patient is kind of exercising, and there's this left ventricular pressure volume loop. Compared to at rest, which of the following changes is kind of observed during moderate to heavy exercise? So what's happening in exercise? Can anybody tell me? What's going to happen to the stroke volume?
Increase.
Preload also increase.
Will increase.
All right. So is it A, is it B, is it C, is it D, or E?
It's A. It's A. It's A,
Of course,
because
everything is gonna
On the
increase, right?
yes,
Yeah. So it's gonna be A. All right. Okay.
yes.
All right, we can come down and see. Yeah. So again, everything is going to increase. There's going to be increased preload. Why? Because the patient is exercising. Myocardial contractility will also be increased. There's going to be increased stroke volume. There's also going to be increase in afterload. So basically, everything is going to increase, and that is why the answer was A over here. Okay. All right. What is this?
All T wave.
Tall T wave.
Oh, sorry.
Premature beat?
Where
Yes,
do you see
actually,
tall
it
T
will.
waves? Where do you see tall T waves?
Hypokalemia.
Hyperkalemia.
Yeah,
Yeah, very good. Where do
hyperkalemia.
you
Yeah.
see, where do you see short T waves?
In I4.
Hypokalemia, very good.
I4.
Hypokalemia, short T waves, tall T waves, hyperkalemia. Hyperkalemia is usually an emergency, so you have to take control. Otherwise, potassium is fatal to the heart. And there was this documentary I was watching, and it's really interesting because the nurse was giving potassium injections to the patient to kill the patient because she had some personal grudges with the patient. And you know what? Once you give potassium injections to the patient, after some time, it will show that the patient died of a heart attack, and there will be no external causes. You cannot define it on laboratory. You cannot prove it on laboratory that it was due to hyperkalemia. Isn't it fantastic? If you want to kill someone, by a heart attack, you can give excess potassium and the patient can die of a heart attack. So that's something interesting. But yeah, so which of the following best represents the relative left ventricular end diastolic volume just prior to the heartbeats represented by the letters? Okay.
E is right.
E, why?
Because we see the more filling time, we may see the more left ventricular and diastolic volume.
All right. Yeah. So we know that there's this thing called premature ventricular contraction, PVCs, and it's usually not that high yield for you to go through. But for information purposes sake, try to remember what that is. Again, when a PVC occurs, premature ventricular contraction, it interrupts diastolic filling of the left ventricle, resulting in a decrease in diastolic volume. And that is why there was an increase in EDV and diastolic volume at the time of post-PVC beat. Again, this is not high yield premature ventricular contraction. They're never going to ask you on USMLE step 1. I don't know why are these questions here, but if you want to go through for information purposes sake, you can kind of go through that. Okay. All right. Next question. Some myocardial cells also have brownish perinuclear cytoplasmic inclusion. What is this? Can anybody tell me what is this?
Lipofuscin.
Lipofuscin. Very good.
Yeah.
The changes described are most consistent which of the following? So there is a 70-year-old man and
Normal
he
aging.
Normal aging.
Normal aging.
Let us finish the question. I mean, yeah, it's normal aging.
Okay, yeah. So we know that these brownish perinuclear cytoplasmic inclusions are lipofuscin, and then lipofuscin, it gets deposited more and more the more you age, and it's because of the result of indigestible byproducts of subcellular membrane lipid oxidation, and it's normal. It doesn't represent any sort of pathology, so you will see them in the heart. You will also see lipofuscin in the skin also. All right, and because there's increased collagen deposition, so you will also see in the skin, in the eyes, everywhere in the body. It's kind of like it represents that the body is aging. All right, next question. Pulse oximetry is 100% on full air. The patient is awake and alert. Pupils are equal and reactive. Heart and lung examination is normal. Okay, everything is normal. Which of the following is cause of the patient's syncope? So what has happened is this 17-year-old boy, he passed out. The patient was standing behind the dugout when he suddenly felt warm and lightheaded. Okay, so this I'm highlighting, very important. And then he remembers awakening on the ground. The patient was unresponsive. He feels fatigued, but does not have chest pain or shortness of breath. Okay, the blood pressure is normal, nothing. Pulse oximetry is normal. What happened? How did he pass out?
Syncope, vasovagal syncope.
Vasovagal.
Vasovagal.
Increased
Very good.
parasympathetic.
Increased
Increased
parasympathetic
parasympathetic
output.
output to the heart.
17 years.
Sympathetic
B.
output to the heart.
Very good. So vasovagal syncope, there was this actor who I forgot his name. He had vasovagal syncope. So what he described his condition was that whenever he used to do gym or whenever he was in a lot of stress, he used to feel nauseous and he used to pass out. That is a classic example of vasovagal syncope. And that is what I want you to remember from this example. Any sort of person who's like an athlete or who's doing anything strenuous and he experienced some sort of nausea, this nausea, nauseous, warm, lightheaded, this sort of aura that you feel when you pass out, that is something kind of very very pinpointed towards vasovagal syncope. So you feel prodrome and there's rapid recovery of consciousness. You don't have to do anything. It's very self it self recovers. You can do upright table testing, but again they never ask you. What I want you to remember is that pain, anxiety, emotional stress. For example, a girl has been read her exam results and she failed and she immediately started sweating and fainted. That's vasovagal syncope. Okay, what's happening is that there's an increase in the parasympathetic tone, and we know the parasympathetic tone, what it does is it reduces heart rate and contractility. Similarly, sympathetic tone is the opposite of that. It's going to increase your heart rate and contractility, and that is why it's really ideal for you to go through that. All right, what if the patient would have directly fainted without any prodrome? Then what?
Baroreceptor.
Sorry, can you repeat that?
Arrhythmia.
A patient faints without any prodrome, that warrants a cardiologic examination. All right, because then that means that's a cardiovascular cause. All right, so if a patient is fainting directly and the patient does not have orthostatic hypotension, the patient did not experience any sort of prodrome, then it may be due to any cardiovascular cause, and you have to do a cardiovascular investigation for that. And on USMLE purposes, that's also the right answer, that you pick the cardiovascular option. That's usually the right answer if the patient faints without any prodrome. Okay. All right. Next question. Agitated normal saline is injected into a peripheral vein to evaluate for abnormal. Sorry, what? Okay. So agitated normal saline is injected into peripheral vein to evaluate for normal right to left shunting. No bubbles are seen in the left side of the heart after several minutes. Which of the following is most appropriate for increasing right-sided heart pressure to reveal an obscured intracardiac shunt? What is this doing? What are they doing? What is this called?
They're looking for the effect. They're looking for the
See if it's patent or not.
All right. Okay. What's the answer?
Valsalva.
E.
Again, so one thing that the embolism does not transfer from the right to the left circulation only in the casing of shunting. If there is shunting going on because of a patent foramen ovale, then the embolization can cause a stroke. Otherwise, it cannot cause a stroke in that condition. The DVT cannot cause a stroke because, again, the pulmonary and the systemic circulation are totally different. And if there's this mixing of the blood, and then only stroke can occur from a DVT. Otherwise, it never really crosses because of a patent foramen ovale. and it causes paradoxical embolization. So what you do is this Valsalva maneuver. There are other maneuvers also, such as there's this, hand grip maneuver that's kind of, done to see the afterload. There's also other types of maneuvers as well. What are the two other types of maneuvers?
Vasovagal.
So there's this Valsalva. What else?
Carotid massage.
No, in terms of heart, what
Leg
in order
raise?
to check for heart murmurs, what type of maneuvers do we see?
Squatting?
Squatting, hand grip,
Leg raise.
passive leg raise. Passive leg raise usually it causes increase in the preload. Squatting, it causes increase in the preload. Hand grip, it causes increase in the afterload.
Standing.
All
Stooping.
right. There's standing maneuver, there's Valsalva. So what Valsalva does is it decreases the preload, right? What murmurs are the loudest with Valsalva?
Right-sided.
What murmurs increase with the Valsalva maneuver?
MPV.
It slows the heart rate.
Mitral
Valsalva
valve
slows.
prolapse and hypertrophic cardiomyopathy.
Welcome.
What? So usually the murmurs decrease with Valsalva, except for MVP and HOCM. They kind of get loud with this Valsalva. All right. What about spotting? In spotting, what?
Decreases, murmur decreases. Mitral valve and hypertrophic cardiomyopathy decreases.
Very good. And the rest of the murmurs will increase.
HOCM,
Okay. What about
HOCM
the
and
hand grip?
MVP decreases.
Very good. What about the hand grip?
Hand grip also decreases.
So
aortic regurgitation VSD increases with hand grip.
Very good. And aortic stenosis and HOCM will decrease with the maneuver. Okay. All right. Okay. Next question. Which of the following list of locations, which most likely corresponds to the order of the points 1, 2, 3, 4, AB, atrioventricular? Okay, so what's happening is the physiologist conducting research on the electrical properties of the heart, measure action potential, conduction velocity at 4 different points with the normal cardiac tissue. Okay, the results expressed in terms of speed of conduction are this. All right, so which is corresponding to what? Which has the highest, fastest, and which has the lowest?
Purkinje has the highest and AV
AV
node has the
node is
lowest.
Purkinje D. Purkinje.
C. Option
C?
C. Yeah.
C.
1, 2, 3,
D.
4.
Very good. Again, cardiac tissue conduction velocity fastest is per
Ah.
kg. And then
Okay, yes, it's true.
Park and the
Park and-
Venture Avenue, PAV, So Purkinje is faster than atrial, then ventricular, and then AV node. All right. Okay, guys, last question for today, and then it's a wrap, and then you guys have your class too, I think. Okay. As a result of drug therapy, the left ventricular pressure volume loop changes from a solid to a dashed line, as seen over here. Okay, which of the following parameters is most likely increased as a result of the change? Where do you see this type of, what's happening to the stroke volume over here?
It's increasing.
Increase.
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 Volume.
Increase stroke
Stroke volume
volume.
increase.
Okay, so what's going to be the answer over here?
C.
C. C.
C.
Did I just give you away the answer? Okay. All right. Yeah. So over here, we know that increase in cardiac contractility shifts the top left corner of the left ventricular pressure volume loop up to the left. It kind of increases stroke volume due to increase in the fraction of LV preload. These cardiac loops are very important. These graphs are very important in the present and first aid. So go through them, very, very high yield. Go through the murmur section of the first aid as well. very high yield. With that, we are done for today. It was an amazing session. You guys were great. Do you guys have any questions for me?
Hi, doctor. Can you explain question number 15, premature ventricular contraction one more time?
Premature. Does anybody else want to explain? I am tired.
What the premature?
What do you want to know about premature ventricular contraction?
That what are those and what was the MCQ, like Z greater than X or X greater than Y?
Hello. Can you guys hear me? Hello.
Yes,
Yeah.
Dr. Ahmed, we
Yes, we
can
can
hear
hear
you.
you.
Yes.
Okay. So don't worry. In the question and answer session, I'll just explain that MCQ. Okay. So Dr. Mahin is tired now. You guys don't have to be worried. Okay. Just let's have 5 minutes of break. And
Hello.
Hello.
Hello, everyone.
You're here. You can.
Dr. Moaz, is it Dr. Moaz?